Welcome to the next case in my Echo Education series. Today looking at a patient with left atrial myxoma, but then actually had a recurrence 10 years later in the right atrium. In terms of atrial myxomas, the recurrence rates report to be around 2 to 3% and more commonly seen in the first few years. Around 10% of myxomas are familial and this type tend to have a higher rate of recurrence. And around 20% of cases are actually right atrial, with even rarer ventricular or atrial myxomas also seen. In terms of the case, the patient was around 60-year-old female. She initially presented in about 2010. She actually had a murmur for investigation. The actual mass detector was quite large and had quite a broad attachment, and there was some involvement in the interatrial septum extending to the right upper pulmonary vein, which required some surgical reconstruction. On a routine follow-up about 10 years later, a myxoma was seen arising from the base of the septal tricuspid valve leaflet. In the study from 2010, it's quite obvious immediately there's a very large left atrial mass there. Interestingly though, if you just tilt over a little bit, the mass actually is not particularly obvious at all, and you can see some abnormality with the back of the picture there. And when you actually center the structure, you can see it's quite large with a broad attachment. It's now close to nearly 4 centimeters across from that view. And it appears relatively fixed when you actually look at the image there. And tilting over towards the RV inflow view, with the left atrium still showing, you can see quite a large mass there. And again, the short axis, you can see why when I tilt it over. In the long axis, if I tilt it over laterally, you could actually miss the abnormality. And again, at least 3 centimeters square in that view. Now looking at the apical 14 chamber view, you can see it arising from the right upper pulmonary vein there. Interestingly, on the colour flow there, it didn't appear to be particularly obstructive. There was some slight acceleration through there, but not particularly obstructive, as I said. And last view here, just the apical view here. As you can say, it's quite low down the atrium when you see it from that view. In the same patient approximately 10 years later, we can see now the left atrium was quite clear, nothing of any concern going on there. Tilting over towards the RV inflow view, when we actually look, we can see a leaflet there, the anterior leaflet, and we can see a leaflet just here as well. And when we look at it, we can see a degree of thickening around the base of that leaflet. And now looking at a short axis view, with the actual mass we can see there is now appearing much larger in comparison, but looking quite obvious there. And we can see a degree of mobility. Unlike the first one, which appeared to be quite adhered to the wall, this one appears to be on a relative stalk in comparison. And again, looking at it there, and the point of attachment appears to be somewhere around the base of that leaflet. And just in view is looking at the view, or looking at the appearance of it there. And again, just looking at that inflow view, we can see it so well, and zooming on it from there. And so the mass is approximately about a centimetre by a centimetre, so not that large at the current time that we're seeing. And then from the 14 chamber view, it can be seen very clearly attached to the leaflet just there. This case was also ended up being surgically resected, decided it was worthwhile to do. So she ended up unfortunately having a second surgical procedure to remove this one. And even from the subcostal view, it can also be seen as well. Thank you for watching the latest in my Echo Education series.